Good evening, everybody. Welcome to expert webinar on recent advances in the management of small vessel vasculitis. This event is organized jointly by Sri Lanka Society of Nephrology and Ceylon College of Physicians. Dear colleague, we are pleased to have a distinguished guest speaker, Professor Charles Pusey, to enlighten us on this important topic today. Professor Charles Pusey qualified from Cambridge University and Guy's Hospital, London, and joined the Royal Air Force, where he gained experience in general and renal medicine. On leaving Royal Air Force, he moved to Hammersmith Hospital as a senior registrar in renal and general medicine to Professor Keith Peters. He started his research on MRC Clinical Research Training Fellowship, and he was subsequently awarded a Wellcome Trust Senior Research Fellowship. This led to his appointment as Senior Lecturer at Royal Postgraduate Medical School, later merged with Imperial College London. He was appointed Professor of Medicine at Imperial College London in 2003. Professor Charles Pusey was active in clinical practice in all aspects of renal medicine. This led a large multidisciplinary vasculitis service and contributed to the general services for many years. He has continued his both clinical and laboratory-based research in parallel, and this work has focused on autoimmunity and inflammation in renal disease, including mechanisms underlying primary and secondary glomerulonephritis. This has helped to develop and taken part in many of the multi-centered trial in ANCA-associated vasculitis. He has published over 500 articles on renal disease, mainly on glomerulonephritis, vasculitis, and antiglomerular basement membrane disease, and contributed chapters to the major textbooks on renal and general medicine. Dear colleagues, we will welcome Professor Charles Pusey to this expert webinar. I invite him to deliver his presentation. Over to you, sir.
Great. Thank you very much for your kind introduction and for inviting me to speak at your webinar series. So if I may, I'll try to start sharing my screen for you. Okay, well, this evening I've been asked to talk about recent advances in the management of small vessel vasculitis. So as you know, vasculitis can be classified according to the Chapel Hill Consensus Conference, depending on the size of blood vessel involved, and a series of short clinical definitions, which we won't go into here. And today I'll be talking about ANCA-associated small vessel vasculitis, which can be divided into microscopic polyangiitis, granulomatosis with polyangiitis, and eosinophilic granulomatosis with polyangiitis. And of course, there is also a renal limited variant. So what is the role of anti-neutral cytoplasm antibodies, or ANCA, in vasculitis? Well, they are specific and sensitive for the diagnosis of small vessel vasculitis, and their pattern and specificity correlate with clinical features and diagnosis. You can see on the top panel cytoplasmic or C-ANCA, which characteristically react with proteinase 3, which are characteristic of GPA. In the lower panel, you can see perinuclear or P-ANCA, which generally react with myeloperoxidase and which are much commoner in MPA and also eGPA. Now, the levels of ANCA correlate with disease activity, and rising levels of ANCA generally predict relapse. And this is better in series, including renal patients. Reducing the levels by techniques such as plasma exchange or the use of rituximab is associated with clinical improvement. And drug-induced ANCA are strongly associated with subsequent development of vasculitis, again proving the link between ANCA and disease. And finally, there's one reported case of maternal fetal transfer. Now, I'm afraid I can't make my pointer work. I don't know if there's anything you guys can do, or if I should just continue without it. Okay, so there's mounting evidence that ANCA are directly pathogenic. Some of this comes from cell culture experiments, but there's also quite a lot of evidence from experimental animal models. And I won't have time to describe all of those today. But we know from in vitro studies that ANCA are capable of stimulating both neutrophils and monocytes to release cytokines, reactive oxygen species, and proteolytic enzymes. They activate complement through the alternative pathway of complement, and they can dysregulate normal neutrophil apoptosis, leading instead to netosis, which is a process leading to release of neutrophil extracellular traps, important in inflammation and autoimmunity. ANCA reduce neutrophil deformability, leading to them being trapped in small vessels, where they can migrate through endothelial cells and ultimately kill the endothelial cells, leading to a necrotizing vasculitis. ANCA-associated vasculitis is a rare disease, the incidence of which varies somewhat across different countries. But in the UK, it's about 20 per million population per year. And GPA and MPA are seen roughly equally, whereas EGPA, previously known as Churg-Strauss syndrome, shown in the pale bars, is much rarer disease. ANCA-associated vasculitis is obviously a systemic disease affecting many organ systems. Both GPA and MPA commonly affect the kidney, hence it is often seen by nephrologists. GPA particularly affects the ENT and upper airways, and both GPA and MPA often affect the lungs. But you will see a wide range of other organ systems are involved, and so ANCA vasculitis can present to almost any specialty. This shows some of the kidney lesions on kidney biopsy, and the characteristic early lesion is segmental fibrinoid necrosis, as you see in this glomerulus here. You can see an area of necrosis under my pointer, and adjacent you can see a red cell cast in the tubule. And if untreated, this will progress to an established cellular crescent. And here you see cells within Bowman's capsule, both proliferating epithelial cells and infiltrating monocytes. And they have compressed the glomerular tuft. You can see in this silver stain, the glomerulus is actually squashed into this corner of the glomerulus. Characteristically, there are lesions of different ages because the disease remits and relapses. And you can see here, there's an active lesion here next to a nearly normal glomerulus, next to a scarred glomerulus. And this is very unlike the crescentic nephritis in anti-GBM disease, where all the crescents are usually the same age. And occasionally, in maybe 15% or so of cases, you can see fibrinoid necrosis of small renal vessels. Other organs commonly affected include the lungs, and GPA particularly causes granulomatous lesions of the lungs, as shown in this image here. And it also commonly affects the eye and the nose. You'll see in this patient here, the CT scan shows a retroorbital granuloma and destruction of the nasal bones. So MPA has a very similar range of manifestations, except it does not characteristically cause this granulomatous disease of the respiratory tract. When it affects the lungs, it often presents acutely with lung hemorrhage. And in the longer term, it can produce interstitial lung disease. It can produce both keratitis and uveitis in the eye, and the characteristic vasculitic skin rash. So how do we treat vasculitis? You will remember that it had a very poor outcome in untreated patients. And in the early series, the 1-year survival was only about 15%. So it was a very severe and life-threatening disease. And the outcome was transformed really in the mid-1970s by the introduction of prednisolone and cyclophosphamide by Fauci and colleagues at NIH. And they got a response in up to 90% of patients. However, they did have to use large doses of steroids and large doses of cyclophosphamide, and complications such as infections and malignancies were common. In the late 1970s, plasma exchange was introduced at the Hammersmith Hospital for severely affected patients. And then in the 1990s, the European Vasculitis Study Group, of which I was a member at that time, developed a series of trials. And these trials have really revolutionized the management of vasculitis. And the initial trials involved the trials of the better use of conventional drugs, both for induction and for maintenance. And these trials of induction and maintenance were separate because there were these two separate components to treatment. More recently, there's been a number of trials of the use of rituximab, the monoclonal antibody which depletes B cells, and there are current ongoing studies of various biologics and small molecules. And although I won't have time to talk about it today, I'd like to remind you of the importance in these trials of patient-reported outcomes and also attempts to personalize treatment according to the individual patient. It's also a benefit if these patients can be treated in a multidisciplinary vasculitis clinic attended by various specialists where that's possible. But I appreciate that that's not always possible in your own hospitals. So what of induction trials in vasculitis? These are all historic trials up to 2017, and I'll summarize them very briefly only. So the NORAM study showed that methotrexate was equivalent to oral cyclophosphamide for induction in patients with early disease or limited disease. Can you see the right-hand side of that slide, or is there a box over it? Because I can't see the right-hand side of my slide. Can you see that, Dr. Nalika, or not? I can't hear you, or Nalina.
I can see.
You can see the whole slide?
Yes.
Oh, lovely, because I can't, but that's fine. The MEPEX study showed that plasma exchange was superior to methylprednisolone in the recovery of kidney function in patients with a creatinine more than 500 or on dialysis. The Cyclops study showed that intravenous cyclophosphamide was equivalent to oral cyclophosphamide in patients with moderately impaired kidney function. And there are then two studies, RituxVas in Europe and RAVE in the United States, showing that rituximab was non-inferior to cyclophosphamide in patients in this study with a creatinine less than 4, and in the UK in all comers. The CLEAR study was then a small and short-term study of the use of avacopan against prednisolone in induction. Avacopan, as you know, is an inhibitor of the C5a receptor. So it's a complement blocking drug. And it was non-inferior to prednisolone in this small study. And I'll come on to that again later. So what of more recent studies? The MyPsych study was recently reported from Europe. And this was a study of mycophenolate against intravenous cyclophosphamide in quite a large number of patients, 140 patients with preserved kidney function. And for induction, they had either MMF for 3 months or intravenous cyclophosphamide, and they all had azathioprine for maintenance. And you'll see on these slides, there was no difference in the time to remission, but the time to relapse was shorter with the MMF group. So patients on MMF relapsed quicker than those receiving the cyclophosphamide. And there was no overall difference in adverse events. So I think this slide shows that in patients with limited disease without severe kidney involvement, mycophenolate might be an alternative where you want to avoid cyclophosphamide. What of methylprednisolone? Now this slide this is not a randomized trial. This is a multi-center retrospective study looking at the use of additional pulse methylprednisolone in severe ANCA vasculitis in patients with a creatinine of more than 500. And you'll be interested to see that there was no difference in either patient survival, shown in this graph, or renal recovery or relapse. But there was a higher risk of infection, as shown here, and of diabetes in the patients treated with intravenous methylprednisolone. So this is a word of caution that there is no good evidence that methylprednisolone is of benefit, and there is now some evidence that it can be of harm. So I think you should all consider carefully whether you want to use intravenous methylprednisolone for induction in vasculitis. A recent study, Rituximab, is looking at both induction and maintenance using rituximab in relapsing vasculitis. And this was quite a large study of 188 patients who'd all had a relapse, all treated with rituximab. And this slide just shows the induction phase. It does not show the relapse phase. And in this slide, you can see that remission, which is the patients in the green bars, red is obviously active disease, patients enter remission, about 90% of patients by 4 months. However, this is quite a long time period when you think about it. It takes 4 months for this to work fully. Once the patient was in remission, they were then randomized to the second part of this trial, comparing maintenance with azathioprine or maintenance with regular rituximab every 4 months. This study is not published yet, but I can give you the preliminary results that regular rituximab was more effective than azathioprine in maintaining remission in this disease. Now, because rituximab alone can take quite a long time to work, and because of the results of the RituxVas trial, which combined rituximab and low-dose intravenous cyclophosphamide, in our hospital, we've developed a protocol called CycloVas, which is combined rituximab, low-dose intravenous cyclophosphamide, and a reduced dose of steroids. And this has proven very effective in a cohort study of 66 patients. 94% were in remission by 6 months, and there was a very sustained fall in B cells at anchor levels. And you'll see that patient and renal survival are very good at 5 years, with a patient survival of 95% and renal survival of 84%. And relapses were uncommon, with major relapses in only 15% of patients. And when we compared these results with those from matched patients from the different UVAS studies, the CycloVas protocol showed a reduced risk of death, kidney failure, and relapse. So this is definitely a protocol worth looking at in future. And because we were encouraged by this result, and because we wish to spare the patient the side effect of steroids, we then used the same rituximab and cyclophosphamide, but with a reduced dose of steroids called the glucocorticoid minimizing regimen, in which patients had only 1 or 2 weeks of steroids orally between their 2 doses of rituximab. And again, this was successful with remission in 96%, sustained depletion of B cells and anchor. However, 4 patients in that first year required the introduction of prednisolone. So this steroid sparing approach does not work in all patients, but it did work in the great majority. And these patients showed a comparable outcome in the short term to the UVAS trials. And my colleague, Dr. McAdoo, has recently compared a larger number of these patients who had the glucocorticoid minimizing protocol with those treated with the full CycloVas protocol, which includes maintenance steroids. And you will see that there is no difference in either patient survival, development of kidney failure, or relapse. However, the patients with the steroid sparing protocol do have a quicker return in their B cells, so they might have a propensity for more relapse in future. So I think this is a very encouraging approach, which deserves further study, perhaps with a randomized controlled trial. Because remember, this is not a trial, this is just a cohort study. However, there's another approach to sparing steroids, and that is the use of alternative agents such as complement blockers. And I mentioned earlier the CLEAR study, which was the short-term study of avacopan. This is the longer-term study of avacopan versus prednisolone for induction in vasculitis. This included over 300 patients with preserved kidney function using avacopan continually for 52 weeks or prednisolone tapering over 26 weeks, following either rituximab or cyclophosphamide induction. And you'll see that remission with avacopan here is non-inferior to prednisolone at 26 weeks, and it's superior to prednisolone at 52 weeks. And there is also a greater increase in GFR in patients treated with avacopan than those treated with steroids. So we don't yet know how avacopan will fit into regular management. It has to go through the licensing procedures, and we have to look at the cost considerations. But it certainly, avacopan looks like a potential agent that can be used instead of steroids. Finally, what of the role of plasma exchange? The PEXIVAS study was the largest study of vasculitis so far. It was published last year in the New England Journal. It contained over 700 patients with severe disease with a GFR of less than 50 or with evidence of lung hemorrhage. And the design was interesting. Patients were randomized first to receive plasma exchange or no plasma exchange, and then they were randomized again to have standard dose steroids or reduced dose steroids. And interestingly, when you look at the long-term outcome of plasma exchange, there was no long-term benefit in terms of a combined outcome of renal failure or death. When you look at the glucocorticoid graph, you see here there was no difference in outcome between reduced dose steroids and standard dose steroids. So I think this makes a very strong case that we should all be using a reduced dose of steroids, because this was a very large study with a long follow-up. And it uses about the same dose of steroids, in fact, as we routinely use in our cyclovas protocol. So I'd recommend everyone looks at that paper and adopts their lower dose protocol. For plasma exchange, you'll see there appears to be maybe a slight benefit of plasma exchange in the short term. And I think we're awaiting short-term analysis of whether plasma exchange helps these patients get off dialysis and whether there is protection from lung hemorrhage. And there are some suggestions that this might be the case. And since the completion of PEXIVAS, a meta-analysis has been performed looking at the role of plasma exchange on development of kidney failure in vasculitis. And you can see that this meta-analysis here includes the PEXIVAS study. That's the bottom study shown here. And the meta-analysis shows that plasma exchange reduces the risk of end-stage kidney failure at 12 months. This was lost in the PEXIVAS study because that showed a long-term combined outcome. So there's a clear benefit of plasma exchange on recovery of kidney function. However, that was offset by an increased risk of infections by 12 months. This is unpublished work, so I'm hoping that will be published in the near future. So may I move in the second half of the talk over to maintenance trials. And here, this summarizes some of the older trials, and I'll deal with those only quickly because you will have had a chance to see these. The Cyclosporin study showed there was no difference between switching to azathioprine by 3 months and carrying on oral cyclophosphamide for a year. And I think almost everyone now avoids long-term oral cyclophosphamide. The Widget trial from America showed that adding etanercept, a TNF blocker, to methotrexate was of no additional benefit at inducing remission. So anti-TNF therapy is not generally used in vasculitis. The Wedgent study from France showed that methotrexate and azathioprine were equivalent. So methotrexate is an alternative for maintenance. And the Improved study from Europe compared MMF and azathioprine. And rather surprisingly, MMF was less effective than azathioprine. I think based on experience with transplantation, everyone thought MMF might be better than azathioprine. But in vasculitis, azathioprine was better than MMF, although MMF is a very acceptable alternative where azathioprine cannot be used. There was then a maintenance study of rituximab from France called the Main-Ritzan study, using 0.5 grams of rituximab 6 monthly and comparing that with azathioprine. There were fewer relapses with the rituximab than with the azathioprine. And that results similar to the one I mentioned earlier in the Rituximab study in Europe. And finally, the Remain study looked at comparing azathioprine continued for 24 months. I think most people use maintenance azathioprine for about 24 months, compared with continuing it for 48 months, looking at relapse-free survival. And there were indeed fewer relapses when you continue the azathioprine for longer, but that was offset by a greater number of side effects. So again, you have to balance the risks in each individual patient. So what of more recent studies? So following the initial Main-Ritzan study, the Main-Ritzan 2 compared the fixed schedule of rituximab against the use of rituximab based on return of B cells and a return or a rise in anchor titer. And when they did that, the relapse rates did not differ between the two groups. This compares fixed schedule with dosing depending on B cells and anchor. However, the tailored group actually received fewer infusions of the drug, which is cost effective and saving them side effects. So I think maybe in future we'll be tailoring rituximab according to B cells and anchor levels. And patients that completed that trial successfully then moved on to Main-Ritzan 3, from the French vasculitis group. And this looked at either stopping rituximab at that point in time in the trial or continuing rituximab for another 18 months. And you can see here that relapse-free survival was better at 28 months if you continue using it to when you stop and just leave the patient on a placebo. So again, it looks like however good rituximab is in the short term, you need to keep giving it to maintain remission. And once you stop rituximab, then like as with other agents, the patient may relapse. And finally, how about the BREVAS study published in 2019? This was a trial of belimumab for maintenance therapy. And belimumab, as you know, is a monoclonal antibody which blocks BLyS or BAFF, the B-cell activating factor, and it's been shown to be effective in systemic lupus and lupus nephritis. And in this study, with over 100 patients who were in remission after induction with either cyclophosphamide or rituximab, they then had either belimumab or placebo together with azathioprine. And you can see there was no significant difference in the probability of having a relapse in those two groups. So belimumab did not seem to have an overall benefit in preventing relapse. However, a subgroup analysis shows that patients who started with rituximab for induction and then belimumab, none of those showed a relapse, suggesting a particular synergy perhaps between those two drugs. And it's possible that belimumab prevents the rebound in B cells sometimes seen after rituximab. And there are current studies ongoing looking at the combination of rituximab and belimumab. So bearing those trials in mind, what would be my recommendation to current approaches to treatment? So for early or mild disease, prednisolone together with either methotrexate, I particularly prefer methotrexate for the upper respiratory disease, or mycophenolate mofetil, as in the MyCyc trial. And that would avoid the use of cyclophosphamide, but only in early or mild cases. For more generalized cases, you would use prednisolone still at the moment, together with cyclophosphamide intravenously, as shown by Cyclops, or alternatively rituximab, as shown in the RAVE and Rituxvas trials, or as shown in our Hammersmith experience, you could combine cyclophosphamide with low-dose rituximab. Though, as I say, that was not a controlled trial. And for patients with severe kidney failure or lung hemorrhage, you would have to consider whether to introduce plasma exchange. The MEPEX study showed a significant benefit of plasma exchange in recovery of kidney function, Pexivas did not show a benefit in the combined outcome, but the meta-analysis, you'll remember, did suggest that plasma exchange was beneficial in recovering kidney function. For maintenance therapy, for an initial period of maintenance, prednisolone together with azathioprine would be first-line choice. And in patients who can't tolerate azathioprine, either MMF or methotrexate would be fine, bearing in mind the patient's preferences and any sensitivities. Or indeed, you could go straight to rituximab, although of course that's a more expensive option. For patients who have relapsed frequently, 6-monthly rituximab is probably the treatment of choice, or a tailored dose of rituximab, depending upon B cells and ANCA, as shown in Main-Ritsan 2. So before I sum up, let me just mention briefly the problem of patients with double positive anti-GBM antibodies and ANCA. And these so-called double positive patients sometimes cause confusion in how they should be managed. So we conducted a study in Europe of anti-GBM patients, double positive patients, 41 anti-GBM, 37 double positives, and a large cohort of single positive ANCA vasculitis as a control. And you'll see here in the top left-hand graph, patient survival was similar in all of these groups. However, renal survival, patients with independent kidney function, was very different. Patients with vasculitis alone had a good outcome, as I've shown you in the various trials. Patients with anti-GBM disease had a rather poor outcome, only about 35% having independent kidney function. And patients who are double positive had a result more similar to anti-GBM disease, but perhaps a little bit better. And we noticed that more double positive patients, in fact, came off dialysis. So if you have a double positive patient with anti-GBM antibodies and ANCA, you might be more likely to use plasma exchange and treat them aggressively, whereas in anti-GBM disease alone, you might argue that the treatment is not worthwhile because recovery is less likely. So I think that probably reflects that in some patients, there's dual pathology in the kidney, with maybe the ANCA vasculitis predominating in those who recover. But when we look at relapses, you'll find the double positive patients relapse just like the vasculitis patients, whereas none of the anti-GBM patients relapsed. So you do not need maintenance therapy for the single positive anti-GBM patients, but you do for the double positive anti-GBM patients, just like you do with ANCA vasculitis. So what of long-term outcome in these cases? This is quite an old paper summarizing outcome in the UVAS trials. And the benefit of this paper is that it compared mortality together with that of an age and sex-matched general population. And you'll see the overall mortality ratio was 2.6 compared with the matched controls. So it has a significant effect on patient mortality, again with about a sort of 75% 5-year survival. And factors influencing survival were increasing age and the presence of stage 5 or above CKD. Now, we've done our own study at the Hammersmith Hospital, over 550 patients, with a median age of 56, 52% were male. They include roughly equal numbers of GPA and MPA, with fewer EGPA and renal-limited vasculitis. They were a severely affected group. 30% were on dialysis at presentation, and nearly 20% had alveolar hemorrhage, of whom 34% were on the ventilator. They were all treated the same way over the years, because we've always used the same type of protocol with prednisolone and cyclophosphamide, or more recently, like rituximab, together with plasma exchange only in severe disease. We found a patient outcome was survival was 87% by 1 year, 76% at 5 years, fairly similar to the UVAS study. We found that survival was predicted by age, by the decade of presentation, by the need for renal replacement therapy, and the presence of diffuse alveolar hemorrhage, but ANCA type did not appear to influence survival. And this just shows the graphs of age, where patients over 70 have a greatly increased mortality. decade of presentation where survival gets progressively better by decade from the 1970s up to the 2000s. So this could be partly improved treatment of vasculitis, also partly management of infection and general management, intensive care and patient care. So a lot of things contribute to that. This shows patients requiring dialysis do much less well than those who do not need dialysis, and patients with alveolar hemorrhage do worse than those who do not have alveolar hemorrhage, showing really that the type of treatment I was talking about earlier, like plasma exchange, if it is a benefit against patients needing dialysis or alveolar hemorrhage, then it's well worth doing. And we looked particularly at those patients with poor kidney function, either the creatinine over 500 or the patients who were actually on dialysis when we started. And with patients with a creatinine over 500, you'll see that the renal survival at 1 year was excellent at 96%, and it was also good at 5 years. And even those dialysis-dependent patients, 59% had independent kidney function at 1 year. So 59% of those had come off dialysis with treatment, suggesting that these patients are well worth treating fully because there's a high chance that they will recover. And when you look at either patient survival or renal survival over the long term, patients who are independent of dialysis, even with a creatinine over 500, have a better patient survival and better renal survival over the years than those who need dialysis. So in conclusion, I've shown you there's strong evidence that ANCA are pathogenic in vasculitis. Standard induction therapy could be with prednisolone and intravenous cyclophosphamide or rituximab. I've shown you some promising results using a combination of rituximab and low-dose intravenous cyclophosphamide, and there are several successful attempts at minimizing corticosteroids, both using the corticosteroid sparing protocol I described and also using avacopan. The role of plasma exchange is still not really clear, so no long-term benefit overall from Pexivas, but I think that patients with severe kidney disease or alveolar hemorrhage might still benefit. And I think you need to await further results from Pexivas and the publication of the meta-analysis. For maintenance therapy, low-dose prednisolone together with azathioprine or MMF is usually the first line. But in patients who can't tolerate those or who have repeated relapses, then either regular or tailored rituximab is very effective for maintenance. And finally, I think I've shown you that long-term outcomes of vasculitis continue to improve, which is extremely good news for all of our patients.
Thank you very much, Professor Charles Pusey, for this very informative, excellent presentation. So we will discuss these few questions.
Of course.
So first I will ask one question, because now in Sri Lanka, what we have mainly faces these infections, right? It's more, which we have much more common infections, and we have, going through with lots of infections like tuberculosis, some fungal infections, all with these immunosuppressions. Now, how do you see at UK in terms of these infections? Are they critical about this outcome, or it's the disease activity is critical about the outcome?
No, I think probably, although I'm sure there are higher rates of infection in certain parts of the world, it's true across the world, actually, that infections are a major problem short term. And one of the studies from Europe showed there was actually a higher mortality from infection in the first year of treatment than there was from active vasculitis. So your question is very relevant. Infection is a major problem. And the question is what contributes to that infection? And several studies have now shown that high-dose steroids are one of the major causes of infection. So that's why we and others are very interested in minimizing steroids, avoiding methylprednisolone if possible, and doing a rapid taper of oral steroids. In the Pexivas study, there was also an increased risk of infection with plasma exchange, And I'm not sure if that's related to access infections or some other factor, but we don't see that personally in our practice at Hammersmith. But I know that was reported in Pexivas. But you're right, the role of infection needs to be balanced against the role of immunosuppression in all of these patients.
So is there a role of prophylactic antibiotic in terms of all these immunosuppression? Do you normally regularly give them on regular prophylaxis like we do for the transplant?
So we regularly use prophylactic cotrimoxazole. And this is obviously prevention against pneumocystis, but there's also good evidence it prevents other severe infections in a European study. So cotrimoxazole is regularly used. Obviously, other antibiotics, we prefer not to use prophylactic antibiotics if possible, but all patients during the acute phase have regular cultures, regular observations, and we have a very low threshold for starting antibiotics. But cotrimoxazole is the main antibiotic we use for prevention.
So it's interesting to know a little bit about the Cyclovas trial you conducted, and it's not yet published. So now, how do you get this prednisolone dose adjustment and cyclophosphamide? Is it a high dose cyclophosphamide or it's a low dose one?
When we combine the rituximab with the cyclophosphamide, we use a very low dose of cyclophosphamide, similar to Eurolupus. So it's about 500 milligrams times 6. I'm sure you're familiar with the Eurolupus protocol.
Yes, yes.
So that gives a maximum of about 3 grams of cyclophosphamide. Whereas in the Cyclops study, even the IV group had 5 or 6 grams and the oral group had about 8 or 10 grams. So it's a much lower dose than in conventional cyclophosphamide treatment. And I think that's why it seems to synergize well with rituximab, but does not cause an increased risk of infection. Because we compared it, as you know, with the European vasculitis studies, and there was not an increased risk of infection using that combination.
So how much prednisolone you use for that particular patients? Are they on 0.5 milligrams, or it's much higher than 0.5, or it's lower than that?
So when the patients start in the normal Cyclovas protocol, they usually start at 1 milligram per kilogram, but reducing very rapidly by, 60 milligrams, 45, 30, 25, 20 at weekly intervals, and then more rapidly thereafter. So their overall exposure to steroids is probably only about 3 grams in the first 6 months, which is about half what the standard dose is. But our dose in Cyclovas is very similar to what was used in the low dose Pexivas. So I think we should all be aiming at that type of low dose. And I mentioned also our small preliminary study of steroid sparing. And there we only use steroids at about 0.5 milligrams per kilogram for 2 weeks between the 2 doses of rituximab. So that's a very, very low dose. But that's an experimental protocol. Whereas the Cyclovas one, we have more experience of. And so do some other centers now as well.
So how about this COVID vaccine and COVID-19 infection and these vasculitis patients? So are you really struggle with them with this COVID-19 period? Or how about the vaccine, the use of vaccine for these patients, especially the patient who had a rituximab?
Yeah, so we've been vaccinating all of our patients, and on normal immunosuppressive drugs, their response after the first immunization is not very good, but their response after the second vaccination is almost as good as healthy volunteers. So once they've had 2 jabs, they're usually fully vaccinated. Patients on rituximab, however, if they're B-cell depleted, show a worse response to vaccination. So we prefer to vaccinate them before we give rituximab, if possible. But if they have had rituximab, we'll still vaccinate them. And we have some evidence, although I didn't show you this today, that although they don't make a good antibody response, most of them make a good T-cell response. So even after rituximab, patients will get a T-cell response to COVID vaccination, which should be partly protective. And with the vaccination, we have seen no particular increased incidence of adverse events. We have seen no flares of vasculitis following the vaccination. But obviously, as you know, COVID can be more severe in patients either on immunosuppressive drugs or with kidney failure. So we do sometimes see more severe disease. But the good news is the vaccination seems to work pretty well.
Yeah, it is working, yes. Even
I'm sure you found the same.
We see a less number of patients, and it's it's coming down. So there's a question posed by the attendee. So what is the recommended azathioprine maintenance dose, and how
So
long?
for azathioprine, after we've completed induction with either cyclophosphamide or rituximab, either way, we switch at 3 months with the cyclophosphamide or later with rituximab to azathioprine. And the normal dose is 2 milligrams per kilogram, but usually I round that down to about 150 milligrams for the first maybe year or so, and then I'd reduce it slowly. And I would tend to try and wean azathioprine off over about 2 years usually. And obviously, I showed you the REMAIN study, which showed you can actually continue for longer. And some of my colleagues like to use it for longer. I always prefer to get patients off a drug if I can. So my preference is to start at about 2 milligrams per kilogram and then wean it off over 2 years.
So last question, so about TPE. So how do you kind of organize TPE? Like, is the very beginning, or you mean after a couple of days of immunosuppression, or how frequently you are going to offer this therapeutic plasma exchange?
So when we use plasma exchange, if a patient comes in with either severe kidney failure requiring dialysis, or a creatinine more than 500, or with alveolar hemorrhage, we regard that as an emergency. We'll plasma exchange them immediately they come in. And obviously, we tend to give the cyclophosphamide immediately after a plasma exchange, although it's not removed very much by plasma exchange. But with rituximab, that's rather different. The rituximab is removed by plasma exchange. And if we use rituximab, we tend to wait 48 hours before the next plasma exchange. But generally, if a patient comes in seriously ill, they can be treated with intravenous cyclophosphamide, with steroids, and with plasma exchange. And we then might give them a break after a week and give them some rituximab and then restart plasma exchange. And generally, we will aim for at least 7 exchanges in the first 2 weeks. And I tend to do it daily for the first week, usually. And the number 7 was really plucked out of the air in those trials. And I tend to tailor it according to a patient. And if the patient still has evidence of ongoing disease, I would probably continue it a bit longer, maybe up to 14. But 7 is our regular number of plasma exchanges. And we always make sure we try and do a full plasma volume exchange, which is usually for an adult, that's about 4 liters. Because doing a smaller volume exchange probably doesn't remove the antibody so effectively. And so when some patients, or some centers say, oh, the plasma exchange isn't working, it's because they're doing it not very often and not very big volume. You need to do it regularly with a decent plasma volume. And as I say, our practice at Hammersmith has only been to use it for those patients with the most severe disease. And I don't think there's any evidence to use it in patients with less severe disease. The PEXAVAS study supports that. But in patients with severe disease, I believe there's still a role.
It's interesting. I listened that your presentation says that after a year, that infection rate is high in people who had undergone TPE. Is there a particular suggestion for that?
We don't know. Oh, the citation? No, because that's part of the meta-analysis, which is not yet published. I'm sorry, I showed you the meta-analysis, and that contains the evidence that infection rates are high, but the kidney failure gets better.
Yes.
So I think, as I said at the beginning of my talk, we must try to think of the patient first at all times, try and personalize treatment. And it's always a balance between how much immunosuppression you give them and how much you risk infection or other adverse events. So I think it's a balance of risk, isn't it? But at least if the patient can tolerate it and you can plasma exchange them, you might save them going on dialysis. And going on dialysis has a very poor long-term outcome in these patients. So if you can stop them having dialysis, that's a good thing. And if they get an infection, you can probably treat it with antibiotics. So I agree we must worry about it. We must be concerned about infection, but it generally doesn't stop me treating the patient.
So it's a very good, fruitful evening for us actually. So we have going through is a very good, excellent presentation, and we learned, I think, a lot from you, sir. So thank you very much for accepting our invitation. It's a quick invitation actually. I must thank Dr. Vasil also to helping me to find you actually. So it's a very good presentation, and we learned a lot. So we'll hope to join you again some point again in a few months time to get some talks on this topic. So on behalf of Sri Lanka Society of Nephrology and Ceylon College of Physicians, I thank you. It's a very excellent and informative presentation. Thank you very much.
Thank you very much. It's been a pleasure to speak to you, and I hope I can be there in person next time.
Thank you very much.
Really nice. Thank you.
Good night.
Good night.